Hello there, fellow viewers. Welcome back to the ERMP and Beyond Interactive MCQ series channel, where we delve into intriguing medical cases designed to challenge and enhance your clinical knowledge. As we navigate through each scenario, I invite you to join me in uncovering the nuances of patient care, diagnosis, and treatment options. My goal is to create an engaging learning environment that not only tests your expertise but also expands it. So, tune in, participate actively, and let's embark on today's educational journey together. Remember, each discussion is a step towards becoming a more skilled and informed healthcare professional. Hit that subscribe button and let's dive right in. Happy learning! Case number 14, a 37-year-old female patient came with a complaint of severe retrosternal chest pain which is referred to the neck and arms. The pain is worsened in supine position and relieved by sitting up and leaning forward. The ECG shows widespread elevation of the ST segments. Cardiac biomarkers are in normal range. What is the most likely diagnosis? A. Myocardial infarction. B. Acute pericarditis. C. Pulmonary embolism. D. Stable angina pectoris. You have 25 seconds to think. The key clinical features in this case are age below 40 years, chest pain which radiates to the neck and severity of the pain changes with body positions. Additional ECG and cardiac biomarkers are given. Let's compare and contrast myocardial infarction, acute pericarditis, pulmonary embolism and stable angina pectoris in terms of the given clinical features. Myocardial infarction describes myocardial cell death caused by interruption of blood supply. Typically this occurs after a thrombotic occlusion of a coronary artery previously narrowed by atherosclerosis. The typical pain associated with MI is often described as a pressure, tightness, or squeezing sensation in the chest. Ischemic pain is often a diffuse and difficult to localize. Generally it may radiate to the shoulder, arm, neck, or jaw. The pain can also radiate to both arms or the right arm. Radiation to both arms or shoulders is a significant predictor of myocardial infarction. Chest pain of myocardial infarction do not vary with body position and with deep breathing or it relieve with taking rest or use of medications such as nitroglycerin, and the discomfort lasts more than 20 to 30 minutes in duration. Myocardial infarction can be asymptomatic in up to 1/3 of patients, painless infarcts or atypical presentations more likely in postoperative patients, the elderly, diabetic patients, and women. Risk factors for myocardial infarction are numerous and include high blood pressure, smoking, diabetes, lack of exercise, obesity, high blood cholesterol, poor diet, and excessive alcohol intake. A family history of heart attacks also increases the risk. The age of onset for myocardial infarction can vary, but it typically occurs in patients over the age of 45, with younger individuals considered atypical cases. The effect of sex on myocardial infarction indicates that men are generally at higher risk, especially at younger ages, but women's risk increases post-menopause. The electrocardiogram is a crucial tool in diagnosing myocardial infarction. During an MI, the ECG can exhibit several key changes indicative of cardiac ischemia and injury. One of the hallmark signs is ST segment elevation, which occurs due to injury of the heart muscle and is a critical indicator of an ongoing infarction. This elevation is measured from the end of the QRS complex to the start of the T wave and is considered significant if it is more than 1 mm, or 0.1 mV, in two contiguous leads. Another important ECG finding is the development of pathological Q waves, which reflect a loss of positive electrical forces due to necrosis of the myocardial tissue. These Q waves are typically more than one-third the height of the ensuing R wave or greater than 0.04 seconds in width. In addition to ST elevation, ST segment depression and T wave inversion can also be observed in myocardial ischemia, which may precede an MI or occur in non-ST elevation myocardial infarction. ST depression is significant when it is horizontal or downsloping and is 0.5 mm at the J-point in 2 or more contiguous leads. T-wave inversions, especially when they are new or in multiple leads, can suggest myocardial ischemia. However, these changes can also be seen in conditions other than MI, such as left ventricular hypertrophy or electrolyte imbalances. Furthermore, the presence of reciprocal changes which are ST depression in leads opposite to those showing ST elevation, can reinforce the diagnosis of MI. These reciprocal changes occur because the ECG captures the electrical difference between injured and uninjured tissue. In some cases, especially in the early stages of MI, hyperacute T waves may be present, which are peaked and broad-based, representing the very beginning of myocardial injury. It is important to note that the absence of reciprocal changes does not preclude the presence of a STEMI, but the presence of reciprocal changes makes it more likely. Certain ECG patterns can suggest the location of the MI. For example, ST elevation in leads V1, V4 suggests an anterior wall MI, while elevation in leads 2, 3, and AVF indicates an inferior wall MI. Lateral wall MIs may show changes in leads 1, AVL, V5, and V6. The pattern of these changes can help pinpoint the affected coronary artery and guide treatment decisions. The evolution of ECG changes over time is significant. Serial ECGs can show the progression from hyperacute T waves to ST elevation, then the development of Q waves, and eventually T wave normalization or inversion as the MI resolves or stabilizes. This progression reflects the dynamic nature of myocardial injury and repair processes. Serum cardiac biomarkers, such as troponins, are released into the bloodstream when heart muscle cells are damaged. Levels of these biomarkers typically rise within 3 to 12 hours from the onset of chest pain, peak at 24 to 48 hours, and return to baseline over 5 to 14 days. Elevated levels of biomarkers like troponin are used to diagnose MI and assess the severity of the attack. Troponins are the preferred biomarkers for the detection of myocardial necrosis and are a Class I indication in the diagnosis of MI. The improved sensitivity and tissue specificity of cardiac troponins compared with creatine kinase MB, CKMB, and other conventional cardiac biochemical markers of acute MI have been well established. Troponin is released early in the course of acute MI. An increased concentration of cardiac troponin is defined as exceeding the 99th percentile of a reference control group. Troponin exceeding this limit on at least one occasion in the setting of clinical ischemia is indicative of myocardial necrosis. Elevated troponin can be detected within 2 to 4 hours after the onset of myocardial injury. Serum levels can remain increased for 4 to 7 days for troponin I and 10 to 14 days for troponin T. Troponins are not only useful for diagnostic implications, but also impart prognostic information and can assist in the risk stratification of patients presenting with suspected acute coronary syndrome. The diagnosis of acute MI requires the increase or decrease, or both, of cardiac biomarkers, preferably troponin, with at least one value greater than the 99th percentile of the upper reference limit and at least one of the following: symptoms of ischemia, ECG changes indicative of active ischemia such as development of pathologic Q waves, new ST segment T wave changes or new left bundle branch block, or imaging evidence of new regional wall motion abnormality or loss of viable myocardium. The type of MI can be classified further depending on the etiology of the infarct. Type 1 MI is typically caused by a primary coronary event such as plaque rupture, while Type 2 MI results from an imbalance in oxygen supply and demand, often in the context of another acute illness. Further subclassifications, such as type 3 MI, sudden death, type 4 MI, post-revascularization, and type 5 MI, post-coronary artery bypass grafting, are also recognized. Pulmonary embolus refers to obstruction of the pulmonary artery or one of its branches by material, such as thrombus, tumor, air, or fat, that originated elsewhere in the body. By far the most common cause of acute pulmonary embolism is a embolization of a blood clot, often originating from the deep veins of the legs. Deep vein thrombosis travels to the lungs and obstructs the pulmonary arteries. This blockage can severely affect the lungs' ability to provide oxygen to the blood, leading to symptoms such as shortness of breath, chest pain, and in severe cases, sudden death. Let's see some terminologies associated with PE. In acute pulmonary embolism, patients typically develop symptoms and signs immediately after obstruction of pulmonary vessels. Some patients with pulmonary embolism may also present subacutely within days or weeks following the initial event. Patients with chronic pulmonary embolism slowly develop symptoms of pulmonary hypertension over many years, which is referred to as chronic thromboembolic pulmonary hypertension. Hemodynamically unstable PE is that which results in hypotension. Hypotension is defined as a systolic blood pressure below 90 mmHg or a drop in systolic blood pressure of above 40 mmHg from baseline for a period more than 15 minutes, or hypotension that requires vasopressors or inotropic support and is not explained by other causes such as sepsis, arrhythmia, left ventricular dysfunction from acute myocardial ischemia or infarction, or hypovolemia. Although hemodynamically unstable PE is often caused by large, or massive, pulmonary embolism, it can sometimes be due to small pulmonary embolisms in patients with underlying cardiopulmonary disease. Thus, the term massive pulmonary embolism does not necessarily describe the size of the pulmonary embolism as much as its hemodynamic effect. Hemodynamically stable pulmonary embolism is defined as pulmonary embolism that does not meet the definition of hemodynamically unstable pulmonary embolism. There is a spectrum of severity within this population ranging from patients who present with small, mildly symptomatic or asymptomatic PE, also known as low-risk pulmonary embolism, to those who present with mild or borderline hypotension that stabilizes in response to fluid therapy, or those who present with right ventricle dysfunction, also known as submassive or intermediate-risk pulmonary embolism. The distinction between hemodynamically stable and unstable PE is important because patients with hemodynamically unstable PE are more likely to die from obstructive shock due to severe right ventricular failure. Importantly, death from hemodynamically unstable PE often occurs within the first 2 hours, and the risk remains elevated for up to 72 hours after presentation. The anatomical locations of PE can be categorized based on the level of the pulmonary arterial tree they affect. Saddle PE lodges at the bifurcation of the main pulmonary artery, often extending into the right and left main pulmonary arteries. Approximately 3 to 6% of patients with PE present with a saddle embolus. Traditionally, saddle PE was thought to be associated with hemodynamic instability and death. However, studies suggest that among those diagnosed with a saddle embolus, only 22% are hemodynamically unstable, with an associated mortality of 5%. Lobar embolisms are clots that lodge in the arteries supplying the lobes of the lungs. Segmental embolisms affect the arteries that branch further into the segments of each lobe, while subsegmental embolisms are even smaller clots affecting the subdivisions of the segmental arteries. Smaller thrombi that are located in the peripheral segmental or subsegmental branches are more likely to cause pulmonary infarction and pleuritis. Most PE move beyond the bifurcation of the main pulmonary artery to lodge distally in the main lobar, segmental, or subsegmental branches of a pulmonary artery. Clot that is in transit through the heart is often classified as a form of PE, even though the thrombus has not yet lodged in a pulmonary artery. Clot in transit is associated with high mortality, up to 40%. Pulmonary embolism can be bilateral or unilateral, depending on whether they obstruct arteries in the right, left, or both lungs. The pathogenesis of PE involves a complex interplay of factors, often summarized by Virchow's triad, which consists of three pathologic events like venous stasis, endothelial injury, and hypercoagulability. Venous stasis refers to the slowing or stopping of blood flow, which can occur during prolonged immobility, such as long flights or bed rest. Endothelial injury, which is damage to the inner lining of blood vessels, can be caused by trauma, surgery, or inflammation. Hypercoagulability is an increased tendency of the blood to clot, which can be due to genetic conditions, some medications, or malignancy. When these factors are present, a thrombus can form, detach, and travel as an embolus to the lungs, where it can cause obstruction. The body's response to the embolus includes the release of neurohormonal substances and inflammatory mediators, leading to vasoconstriction and increased pulmonary vascular resistance, further compromising pulmonary circulation and cardiac output. Risk factors for pulmonary embolism are similar to those for venous thromboembolism in general. Risk factors can be classified as inherited, or genetic, and acquired. Genetic risk factors include factor V Leiden and the prothrombin gene mutation. Acquired risk factors can be further subclassified as provoking recent surgery, trauma, immobilization, initiation of hormone therapy, active cancer, or non-provoking, example like obesity, heavy cigarette smoking. Pulmonary emboli are typically multiple, with the lower lobes being involved in the majority of cases. Once thrombus lodges in the lung, a series of pathophysiologic responses such as lung infarction, impaired gas exchange or obstructive shock can occur. Pulmonary embolism has a wide variety of presenting features, ranging from no symptoms to shock or sudden death. The most common presenting symptom is dyspnea followed by chest pain, classically pleuritic but often dull, and cough. However, many patients, including those with large PE, have mild or nonspecific symptoms or are asymptomatic. Less common presentations include transient or persistent arrhythmias, commonly atrial fibrillation, presyncope, syncope, and hemodynamic collapse, which occur in less than 10% for each. Hoarseness from a dilated pulmonary artery is a rare presentation, Ortner syndrome. The onset of dyspnea is frequently, but not always, rapid, usually within seconds, in 46%, or within minutes, in 26% of cases. Dyspnea may be less frequent in older patients with no previous cardiopulmonary disease. Dyspnea is more likely to be present in patients who present with PE in the main or lobar vessels. The quality of chest pain in PE can be quite variable, but it is often described as a sharp, stabbing pain that is pleuritic chest pain. This pain typically arises from the irritation of the pleura, which are the two thin layers surrounding the lungs and lining the chest cavity. Radiation of the pain can occur, and it may spread to the shoulder or the upper part of the abdomen. However, the pain associated with PE is most commonly localized to the area over the affected lung. Aggravating factors for the pain include physical exertion, which can increase the demand on the heart and lungs, potentially exacerbating the pain. Additionally, coughing, deep breathing, and certain movements that involve the upper body can intensify the discomfort. The positional effect on chest pain in PE is less pronounced than in conditions such as pericarditis, where the pain may change with body position. In PE, The pain is typically persistent and does not significantly vary with different positions. Acute pulmonary embolism can lead to various electrocardiogram changes, which reflect the strain and overload on the right side of the heart due to the obstruction of the pulmonary arteries. The most common ECG finding in PE is sinus tachycardia, present in approximately 44% of cases. Other notable changes include a complete or incomplete right bundle branch block, which occurs due to delayed right ventricular depolarization and is seen in about 18% of patients. Right ventricular strain pattern, characterized by T-wave inversions in the right precordial leads, V1 to V4, and sometimes the inferior leads 2, 3, and AVF, indicates high pulmonary artery pressures and is observed in roughly 34% of cases. Right axis deviation is another finding, present in 16% of patients, and in extreme cases, it may manifest as pseudo-left axis deviation due to an axis between 0 and -90 degrees. The classic S1, Q3, T3 pattern, which includes a deep S wave in lead 1, Q wave in lead 3, and inverted T wave in lead 3, is associated with PE but is neither sensitive nor specific for the condition. A dominant R wave in V1 can be a sign of acute right ventricular dilatation, and right atrial enlargement, or P pulmonale, is indicated by a peaked P wave in lead 2 greater than 2.5 mm in height. Clockwise rotation of the heart, due to right ventricular dilatation, may shift the R/S transition point towards V6, maintaining an S wave in V6, which is known as the pulmonary disease pattern. Atrial tachyarrhythmias, such as atrial fibrillation or flutter, may also be present and are seen in about 8% of cases. Nonspecific ST segment and T wave changes, including both elevation and depression, are quite common, occurring in 70% of patients with PE. The simultaneous presence of T-wave inversions in the inferior and right precordial leads is highly specific for PE, with specificities of up to 99%. The pathophysiology behind these ECG changes includes dilation of the right atrium and ventricle, leading to a shift in the heart's position, right ventricular ischemia, and increased sympathetic nervous system stimulation due to pain, anxiety, and hypoxia. Despite these characteristic ECG findings, it's important to note that the ECG is neither sensitive nor specific enough to diagnose or exclude PE on its own. The most common findings are tachycardia and nonspecific ST segment and T-wave changes, which occur in 70% as described earlier. The levels of troponin and B-type natriuretic peptide are also elevated in PE. Serum troponin I and T levels are useful prognostically but not diagnostically. As markers of right ventricular dysfunction, troponin levels are elevated in 30 to 50% of patients who have a moderate to large PE and are associated with clinical deterioration and death after PE. Troponin elevations usually resolve within 40 hours following PE, in contrast to the more prolonged elevation after acute myocardial injury. Elevated BNP has limited diagnostic value in patients suspected of having PE. However, elevated BNP or its precursor, N-terminal proBNP, may be useful prognostically for risk stratification of patients diagnosed with acute PE. Arterial blood gas testing is another important diagnostic tool. It measures the levels of oxygen and carbon dioxide in the blood, providing insight into the lungs' ability to exchange gases. Unexplained hypoxemia in the setting of a normal chest radiograph should raise the clinical suspicion for PE and prompt further evaluation. However, while often abnormal among patients suspected of having PE, ABGs can be normal in up to 18% of patients with PE. However, abnormal gas exchange may be due to, and or worsened by, underlying cardiopulmonary disease. An elevated D-dimer alone is insufficient to make a diagnosis of PE, but can be used to rule out pulmonary embolism. D-dimer testing is best used in conjunction with clinical probability assessment. For patients in whom the risk of PE is thought to be low, a normal D-dimer that is below 500 nanogram per milliliter, fibrinogen equivalent units, effectively excludes PE, and typically no further testing is required. This includes patients who have had a prior PE and those with a delayed presentation and hospitalized patients. In contrast, an elevated D-dimer, above 500 nanogram per milliliter, should prompt further testing with diagnostic imaging. For most patients in whom the risk of PE is thought to be intermediate, a normal D-dimer which is below 500 nanogram per milliliter also effectively excludes PE, and typically no further testing is required. However, some experts believe that a subset of patients in the intermediate risk category, for example those in the upper zone of the intermediate range, such as those with Wells score 4 to 6, or patients with limited cardiopulmonary reserve, should undergo imaging based upon the higher probability of PE in these patients, so the sensitivity of D-dimer is not as good. For patients in whom the risk of PE is thought to be high, a normal D-dimer is not as helpful for excluding the diagnosis. While a negative D-dimer result does reduce the likelihood of PE, it does not reduce it sufficiently to rule out the diagnosis, with some data suggesting a prevalence of PE of 5% or more in this population. These patients should undergo diagnostic imaging, preferably with CT pulmonary angiography. We will discuss on CT pulmonary angiography soon. Chest radiographs are neither sensitive nor specific for diagnosing pulmonary embolism. They are often used to rule out other differential diagnoses rather than for the direct diagnosis of PE. In cases of pulmonary embolism, chest X-rays may show nonspecific findings which can include pleural effusions, present in about 35% of cases. But a normal chest radiograph can be seen in 12 to 22% of patients. Specific signs on a chest radiograph that suggest pulmonary embolism, such as Westermarck's sign or Hampton's hump, are quite rare. Westermarck's sign indicates a regional oligemia or decreased blood flow demonstrated as a sharp cutoff of pulmonary vessels with distal hypoperfusion in a segmental distribution within the lung, while Hampton's hump is a shallow, wedge-shaped opacity at the lung periphery. Another finding could be a dilation of the pulmonary arteries. Despite these potential indicators, the absence of such signs on a chest X-ray does not exclude the diagnosis of pulmonary embolism. For a definitive diagnosis of pulmonary embolism, CT pulmonary angiography is considered the gold standard for diagnosis. The key diagnostic feature of pulmonary embolism on a CT pulmonary angiography is the presence of filling defects within the pulmonary arteries. These defects are areas where blood clots obstruct the normal flow of blood. When viewed in cross-section, these clots can give the appearance of a central filling defect surrounded by a rim of contrast, often referred to as the polo mint sign. This sign indicates that the clot is surrounded by blood that has been opacified by the contrast agent used during the scan. Other findings on a CT pulmonary angiography that may indicate pulmonary embolism include enlargement of the pulmonary arteries, right ventricular dilation due to increased strain, and infarcts in the lung tissue, which may appear as wedge-shaped areas of decreased attenuation. CT pulmonary angiography may be relatively contraindicated in patients with a history of moderate to severe iodinated contrast allergy or in patients with renal insufficiency. Ventilation perfusion scanning is mostly reserved for patients in whom CTPA is contraindicated or inconclusive, or when additional testing is needed. A normal chest radiograph is usually required prior to ventilation perfusion scanning. Scans performed on patients with abnormal chest radiographs more likely to result in false positives as the images rarely appear normal or low probability of PE in such patients. The results of a ventilation perfusion scan are typically reported in terms of probability, as low, intermediate, or high probability of pulmonary embolism. The interpretation of the scan is based on the pattern and size of any ventilation and perfusion defects. A mismatch, where there is good ventilation but impaired perfusion, is more suggestive of PE. In contrast, a match between poor ventilation and perfusion may indicate other lung conditions. The risks associated with a ventilation perfusion scan are generally low. The amount of radiation exposure is comparable to other radiologic procedures and is considered safe for most patients. However, it is not typically recommended for pregnant women. Echocardiography can diagnose pulmonary embolism when thrombus is visualized in the proximal pulmonary arteries, although this is a rare phenomenon. Although not definitive, the diagnosis of PE is supported on echocardiography by the presence of clot in the right heart or new right heart strain. The demonstration of any clot or new strain in hemodynamically unstable patients with suspected PE may be useful if a rapid or presumptive diagnosis is required for initiation of treatment in hemodynamically unstable patients. Approximately 30 to 40% of patients with PE have echocardiographic abnormalities indicative of RV strain or pressure overload. Regional wall motion abnormalities that spare the right ventricular apex, which is called McConnell's sign, are insensitive, with sensitivity of only 77% for the diagnosis of PE, but, in those who demonstrate this sign, it may be used to distinguish patients with RV strain from acute PE from those with pulmonary hypertension, who tend to have global RV dysfunction. In general, RV strain is insensitive and nonspecific. The Wells criteria for pulmonary embolism is a clinical tool used to assess the probability of PE in patients who present with symptoms suggestive of PE. The criteria consist of several elements, each assigned a certain number of points based on their association with PE. These elements include clinical signs and symptoms of deep vein thrombosis, such as leg swelling and pain, an alternative diagnosis being less likely than PE, tachycardia, heart rate over 100 beats per minute, immobilization or surgery in the recent past, previous DVT or PE, hemoptysis, and the presence of malignancy with treatment within the last 6 months or currently under palliative care. A score of 0 to 1 indicates a low probability, 2 to 6 indicates a moderate probability, and a score greater than 6 suggests a high probability of PE. In some models, scores are simplified into 2 categories where a score of 4 or less indicates PE is unlikely, and a score of 4.5 or higher indicates PE is likely. The Wells criteria serve as a guide to decide on further testing, such as D-dimer tests or imaging studies like CT pulmonary angiography, to confirm the diagnosis of PE. Stable angina, also known as angina pectoris, is a condition characterized by chest pain or discomfort that typically occurs with activity or stress. It is caused by reduced blood flow to the heart muscle due to coronary artery disease, which means the heart muscle isn't getting enough oxygen-rich blood during times of increased demand, such as physical exertion or emotional stress. Myocardial oxygen demand is primarily determined by heart rate, contractility, and ventricular wall tension. An increase in heart rate raises the frequency of contraction, thus increasing oxygen demand. Contractility, referring to the strength and speed of heart muscle contractions, also elevates oxygen demand when enhanced. Ventricular wall tension, influenced by the pressure within the heart during contraction and the size of the heart chamber, further dictates the oxygen needs of the myocardium. Conversely, myocardial oxygen supply can be decreased by factors such as coronary artery disease, which narrows the arteries due to plaque buildup, and blood clots that can obstruct blood flow. Additionally, coronary artery spasms, temporary constrictions of the artery walls, can reduce or halt blood flow to the heart muscle. Ensuring a balance between oxygen supply and demand is crucial for the healthy functioning of the heart and to prevent conditions such as myocardial ischemia. Most patients with myocardial ischemia will present with classic angina pectoris as the primary clinical manifestation. Angina is usually characterized more as a discomfort rather than pain. Terms frequently used by patients include squeezing, tightness, pressure, constriction, strangling, burning, heartburn, fullness in the chest, band-like sensation, knot in the center of the chest, lump in throat, ache, heavy weight on chest, like an elephant is sitting on chest, like a bra too tight, and toothache, when there is radiation to the lower jaw. In some cases, the patient cannot qualify the nature of the discomfort, but places his or her fist in the center of the chest, known as the Levine sign. It is generally not described as sharp, dull aching, knife-like, stabbing, or pins and needles-like. Angina is typically gradual in onset and offset, with the intensity of the discomfort increasing and decreasing over several minutes. Since angina is a referred discomfort, patients tend to have the same quality of chest discomfort with recurrent ischemic episodes. Generally, it is felt in the same location. The discomfort is generally the same prior to or with a myocardial infarction and is the same quality as prior to revascularization by either surgery, although the location may be different due to disruption of neural innervation of the heart or percutaneous coronary intervention. Angina is a constant discomfort that does not change with respiration or position. It is also not provoked or worsened with palpation of the chest wall. However, the presence of a change in pain with respiration, or position, or pain elicited by palpation does not exclude angina as the cause. Angina is referred to the corresponding dermatomes of C5 to C6 and T1 to T6 that supply afferent nerves to the same segments of the spinal cord as the heart. Thus, angina often radiates to other parts of the body, including the upper abdomen, or epigastric, shoulders, arms, upper and forearm, wrist, fingers, neck and throat, lower jaw and teeth, but not upper jaw, and rarely to the back, specifically the interscapular region. Radiation to both arms is a stronger predictor of acute myocardial infarction. The location and radiation of angina is usually the same each time. Occasionally, the location and radiation, but not quality, may be different after bypass surgery due to the disruption of the neural innervation of the heart. Angina is often elicited by activities and situations that increase myocardial oxygen demand, including physical activity, cold, emotional stress, sexual intercourse, meals, or lying down, which results in an increase in venous return and increase in wall stress. Angina occurs more commonly in the morning due to a diurnal increase in sympathetic tone. Classic angina is often relieved with termination of the provoking factor. Angina generally lasts for 2 to 5 minutes. It is not a fleeting discomfort, which lasts only for a few seconds or less than a minute, and it generally does not last for 20 to 30 minutes, unless the patient is experiencing an acute coronary syndrome, especially myocardial infarction. Factors that reduce oxygen demand or increase oxygen supply will result in relief of angina. However, relief of chest discomfort with nitroglycerin is not specific for angina, since a similar response may be seen with esophageal spasm or other gastrointestinal problems, as nitroglycerin also relaxes smooth muscle. The risk factors for developing stable angina are similar to those for coronary artery disease, as angina is often a symptom of underlying heart disease. Major risk factors include advanced age, smoking, high blood pressure, high cholesterol levels, diabetes, and a family history of heart disease. Lifestyle factors such as physical inactivity, obesity, and stress also contribute to the risk. Additionally, conditions like anemia or hyperthyroidism can exacerbate the risk of stable angina by increasing the heart's oxygen demand. The ECG is usually normal between attacks. During an episode of anginal attack, there may be a transient ST segment depression, which is the most common finding and occurs because of the subendocardial ischemia that affects the inner layer of the heart wall. Symmetrical T-wave flattening, inversion or tall, pointed, upright T-wave may appear, reflecting the repolarization abnormalities secondary to ischemia. If the angina is provoked by exertion, an exercise stress ECG should be performed. Myocardial ischemia is suggested by an ST segment depression greater than or equal to 1 mm. Note that ST elevation may occur in Prinzmetal's angina. It's important to note that these changes are usually transient and revert to normal when the angina episode resolves. In some cases, especially during an exercise stress test, these ECG changes can be provoked to confirm the diagnosis of stable angina pectoris. Exercise ECG testing may reveal exercise-induced myocardial ischemia. Exercise ECG is abnormal in 85% of patients with angina. However, at rest, the ECG of a patient with stable angina may often be normal. Remember that serum cardiac biomarkers are typically normal in stable angina as there is no myocardial infarction. Acute pericarditis is an inflammatory condition of the pericardium that is the fibrous sac surrounding the heart. The term myopericarditis, or perimyocarditis, is used for cases of acute pericarditis that also demonstrate myocardial inflammation. Myopericarditis is used for cases with prevalent pericarditis and normal ventricular function. Perimyocarditis is used for cases with prevalent myocarditis and if ventricular function is reduced with evidence of new wall motion abnormalities or reduced ventricular function. The age of onset can vary, but it is more common in men, particularly between the ages of 20 and 50. Patients typically report acute, sharp or stabbing, retrosternal chest pain that improves when sitting up or leaning forward. This pain characteristic is due to the pericardium's proximity to the sternum and its aggravation by movements that stretch the inflamed pericardial layers such as lying down or it get worsened during taking deep breaths. The etiology of acute pericarditis can be multifactorial and is often idiopathic, meaning its exact cause is unknown. However, the etiology can be classified into infectious and non-infectious causes. Viral infections are the most common infectious cause, with Coxsackie-virus, echovirus, and HIV being frequently implicated. Bacterial infections, although less common, can also lead to pericarditis, particularly in immunocompromised individuals or those with a history of invasive cardiac procedures. Non-infectious causes include systemic inflammatory diseases like rheumatoid arthritis and lupus, myocardial infarction, trauma, post-cardiac injury syndrome following heart surgery and malignancy. Medications, particularly those that affect the immune system, can also induce pericarditis. On physical examination, the most characteristic sign is a pericardial friction rub, which is a scratchy or squeaking sound heard over the heart, best detected with the diaphragm of the stethoscope pressed firmly on the chest with the patient leaning forward. This sound is produced by the rubbing of the two inflamed layers of the pericardium and can be intermittent, so it may require several listens to detect. It is reported to be present in up to 85% of cases and is pathognomonic for acute pericarditis. Auscultation of pericardial friction rub is highly specific for acute pericarditis. The specificity approaches 100%. Additionally, patients may exhibit Ewert's sign, also known as the pin sign, where dullness to percussion and bronchial breath sounds, bronchophony or decreased breath sounds are found at the left lower lung field due to compression by a large pericardial effusion. Other findings may include fever, tachycardia, and symptoms of pericardial effusion, such as dyspnea. In more severe cases, signs of cardiac tamponade may be present, including hypotension, pulsus paradoxus, a drop in blood pressure during inspiration, elevated jugular venous pressure, and muffled heart sounds. These signs indicate a significant accumulation of fluid within the pericardial space, exerting pressure on the heart and impairing its function. The diagnosis of acute pericarditis is primarily clinical but can be supported by ECG changes, the presence of pericardial effusion on imaging, by the presence of elevated inflammatory markers like white blood cells, erythrocyte sedimentation rate, and C-reactive protein. The first level of diagnostic tests typically includes an ECG, which can reveal specific changes like ST elevation or PR depression. Chest X-rays may be performed to check for an enlarged cardiac silhouette due to fluid accumulation around the heart. An echocardiogram can visualize the pericardium and assess for the presence of pericardial effusion. Complete blood count with differential is performed to check for signs of infection or inflammation. Elevated levels of C-reactive protein and increased erythrocyte sedimentation rate are indicative of inflammation. Additionally, cardiac enzymes such as troponin may be elevated if there is myocardial involvement. Cardiac troponin levels are elevated in 30% to 50% of cases due to epicardial inflammation rather than myocyte necrosis. In some cases, specific tests for autoimmune markers are conducted if an autoimmune etiology is suspected. If these initial tests support the suspicion of pericarditis, second-level diagnostic tests may be employed. These include advanced imaging modalities like chest CT or MRI to provide a more detailed view of the pericardium and to assess the extent of inflammation or fluid accumulation. In some cases, pericardiocentesis may be necessary for analysis, including bacterial cultures if an infectious etiology is suspected. On an electrocardiogram, acute pericarditis typically presents with widespread concave ST segment elevation and PR segment depression across most limb leads and precordial leads, except for lead AVR where reciprocal ST segment depression and PR segment elevation are observed. This pattern reflects the inflammation's effect on the heart surface. As the condition progresses, the ECG changes evolve through 4 stages of evolution. Acute pericarditis typically presents at stage 1, with widespread concave street elevation and Puerto Rico depression, V26, and leads 1, 2, AVL and AVF. In the first stage, which occurs during the first 2 weeks, the aforementioned ST and PR changes are present. The second stage, occurring 1 to 3 weeks after onset, is characterized by the normalization of ST segments and generalized T-wave flattening. The third stage, spanning 3 weeks to several weeks, features T-waves that become inverted. Finally, in the fourth stage, the ECG either returns to normal or persistent T-wave inversions are observed. It's important to note that less than half of patients experience all 4 stages, and the progression may not follow this typical pattern. The ECG changes are relative to the baseline formed by the TP segment, and the degree of ST elevation is typically modest, ranging from 0.5 to 1 mm. Sinus tachycardia is also common due to pain or associated pericardial effusion. These ECG findings are crucial for differentiating acute pericarditis from other conditions such as myocardial infarction, as both can present with chest pain and ST elevations on the ECG. However, the presence of diffuse ST elevation, PR depression, and the specific evolution through stages are indicative of pericarditis. Acute pericarditis is diagnosed based on a combination of clinical features, which include typical chest pain, pericardial friction rub, electrocardiographic changes, and pericardial effusion. The chest pain associated with acute pericarditis is often described as sharp and pleuritic, worsening with inspiration and improving with sitting up and leaning forward. A pericardial friction rub, which is a scratchy or squeaking sound heard over the heart, is suggestive of pericarditis but is not always present. Electrocardiographic changes indicative of acute pericarditis include widespread ST segment elevations and PR segment depressions, which typically are observed at stage 1. Additionally, an echocardiogram may reveal a pericardial effusion, which is the accumulation of fluid in the pericardial space. Acute pericarditis presents certain features that may elevate a patient's risk profile and necessitate hospital admission for more intensive care. These high-risk features include a high fever exceeding 38 degrees centigrade, which indicates a systemic inflammatory response, a subacute onset, suggesting a more insidious and potentially severe disease process, and a large pericardial effusion or cardiac tamponade, which are direct threats to cardiac function and hemodynamic stability. Additionally, a lack of response to anti-inflammatory therapy after 1 week is a concerning sign that standard treatment protocols may be insufficient, and evidence of myocardial involvement indicates that the inflammation has affected the heart muscle itself, potentially leading to more serious complications. Other factors that contribute to a higher risk status are immunosuppression, the use of oral anticoagulation, which can complicate the clinical picture due to the increased risk of bleeding, and a history of trauma. High-risk patients with acute pericarditis should be admitted to the hospital in order to initiate appropriate therapy and expedite a thorough initial evaluation. Patients with high-risk features are at increased risk of short-term complications and have a higher likelihood of a specific disease etiology. Conversely, patients with uncomplicated or low-risk acute pericarditis can usually be evaluated and sent home, with outpatient follow-up to assess the efficacy of treatment and complete the diagnostic evaluation. Treatment strategies for pericarditis are guided by the findings of these diagnostic tests and the overall clinical assessment, ranging from anti-inflammatory medications to more invasive procedures like pericardiectomy in severe cases. The treatment of acute pericarditis typically involves a combination of medications to reduce inflammation and pain. Non-steroidal anti-inflammatory drugs, such as ibuprofen or aspirin, are often the first line of treatment to alleviate the pain and decrease the inflammation. Colchicine may be used in conjunction with non-steroidal anti-inflammatory drugs to treat acute pericarditis and to prevent recurrences. In more severe cases, corticosteroids like prednisone may be prescribed, especially if the patient is unable to tolerate non-steroidal anti-inflammatory drugs or if the pericarditis is believed to be due to an autoimmune condition. For cases where pericarditis is caused by a bacterial infection, antibiotics are administered. If the pericarditis has led to a significant accumulation of fluid around the heart, causing cardiac tamponade, a pericardiocentesis may be necessary. In chronic or recurrent cases, where the pericardium becomes thickened and constricts the heart, pericardiectomy may be required. Let's summarize what we have discussed so far. Acute pericarditis is an inflammatory condition of the pericardium that can present with sharp, retrosternal chest pain which worsens with lying down and improves with sitting up or leaning forward. The ECG typically shows diffuse ST segment elevations and PR depressions. In contrast, stable angina pectoris, often due to coronary artery disease, presents with chest pain on exertion that is relieved by rest or nitroglycerin. ECG may show reversible ST segment depression during pain. Myocardial infarction, characterized by the death of cardiac muscle due to ischemia, presents with severe, persistent chest pain and is associated with specific ECG changes such as ST segment elevation, pathological Q waves, and T wave inversions, depending on the infarction stage. Cardiac biomarkers like troponins are elevated in MI due to myocardial cell death. Myocarditis, an inflammation of the myocardium, can mimic MI symptoms but often has a viral etiology. It may show ST segment and T wave nonspecific changes on ECG, and biomarkers such as troponin can be elevated, reflecting myocardial injury. Pulmonary embolism typically causes sudden-onset pleuritic chest pain, dyspnea, and may show ECG signs of right heart strain, such as S1Q3T3 pattern, right bundle branch block, or T wave inversions in the right precordial leads. Cardiac biomarkers may be normal or show a mild increase in troponins due to right ventricular strain. We finish our discussion here. I hope you find the discussion helpful. Thank you for watching. Like, comment and subscribe.